Cancer is a chronic disease. So, why is pain still a problem? My name is Dr. Arti Ori. I'm a pain physician at Mass General Brigham, Harvard Medical School. In terms of my disclosures, I am a consultant for the Medtronic Targeted Drug Delivery Advisory Board. So, chronic pain in cancer survivors. Cancer survivors we define as people who've received a diagnosis of cancer at any time in their lives. In 2016, there was found to be almost 15.5 million cancer survivors in the United States. This number is expected to increase to nearly 20 million by 2026, since nearly half of cancer survivors live longer than 10 years. Studies show that pain occurs in approximately 20 to 50% of cancer survivors. So, chronic pain in cancer survivors is a common and a complex issue. It is often due to a combination of factors associated with the disease itself, with treatments for the cancer, and also underlying psychological and physiological changes that patients with cancer experience. Approximately 30% of cancer survivors, unfortunately, do not receive pain medication proportional to their pain intensity. The primary causes of pain in cancer survivors include surgery-related pain, chemotherapy-induced peripheral neuropathy, radiation therapy effects, bone pain and bone-related conditions, hormone therapy-related pain, neuropathic pain syndromes, psychological and central sensitization factors, autoimmune and inflammatory responses, residual tumor or recurrence of the cancer, and lifestyle and physiological changes. We will be discussing these primary causes in further detail now. In terms of surgery-related pain, we see surgery resulting in post-surgical neuropathic pain. Certain cancer surgeries often involve nerve damage, either intentionally to reduce symptoms or as a side effect of tumor removal, leading to neuropathic pain. Post-surgical neuropathic pain is common in procedures involving the breast, such as mastectomy, the chest and chest wall, the head, the neck, or the abdomen. This often results in chronic pain syndromes that may sound familiar to you: post-mastectomy pain, post-thoracotomy pain, post-radical neck dissection pain, and post-amputation pain syndromes, as well as brachial or lumbosacral plexopathy. Phantom limb pain can also result from surgery. Patients who have undergone amputation, often for bone or soft tissue cancers, can then experience phantom limb pain where the brain continues to perceive pain from the missing limb. Scar tissue and adhesions from surgery can create significant physical discomfort. Adhesions, which are bands of scar tissue that bind together internal organs, may cause long-term pain in cancer survivors. An often overlooked cause of pain related to cancer treatment is myofascial pain syndromes. These myofascial pain syndromes can often result from fibrosis and scarring as a result of radiation or surgery. An example is radiation fibrosis that could be a significant cause of shoulder pain, pain in the chest wall contiguous with the shoulder, as well as limited range of motion of the shoulder. This can occur in breast cancer, Hodgkin's lymphoma, or head and neck cancers as a result of radiation to the affected area. Chemotherapy-induced peripheral neuropathy, CIPN, is a symmetrical distal sensory neuropathy in a stocking glove distribution. Chemotherapy-induced peripheral neuropathy can be painful, causing burning pain or shooting, stabbing pain, or non-painful, resulting in simply numbness that is not uncomfortable. Certain chemotherapeutic agents, such as platinum-based drugs like cisplatin, taxanes like paclitaxel, and vinca alkaloids, can damage peripheral nerves and cause neuropathic pain. This leads to chemotherapy-induced peripheral neuropathy. Numbness, tingling, burning sensations, or sharp stabbing pain that can be present long-term, long after the chemotherapy has ended. The risk of chemotherapy-induced peripheral neuropathy and how long it lasts, its chronicity, depends often on the type of chemotherapy used, the dosage, and the duration of chemotherapy. Cancer survivors who've had a high cumulative dose of chemotherapy are of significant risk for developing chemotherapy-induced peripheral neuropathy. In addition, amongst those patients at a higher risk are those who already have a pre-existing painful neuropathy, either from diabetes or other cause, for example, metabolic causes. Patients also at higher risk of developing chemotherapy-induced peripheral neuropathy include those who've been treated with a combination of multiple neurotoxic agents, resulting from the additive effect of this combination of neurotoxic agents. And patients of older age are more susceptible to chemotherapy-induced peripheral neuropathy development. Looking at radiation therapy effects, we've touched on this before. Radiation-induced fibrosis can cause scarring and fibrosis in tissues, in muscles, and in nerves in the treatment area. This can result in stiffness in the area, decreased mobility, for example, of a specific joint, and long-term chronic pain. Unfortunately, the effects from radiation-induced fibrosis are often long-term. Radiation therapy can also cause a brachial plexopathy. In head and neck or breast cancer treatments, radiation directed to the area may damage the brachial plexus, which is the nerve network that supplies the entire arm. This damage to the brachial plexus can lead to pain in the distribution of the nerves of the brachial plexus, as well as numbness and even weakness in that upper extremity. Radiation therapy can also cause lymphedema. Radiation to lymph nodes, especially in the breast, in gynecological cancers, and head and neck cancers, may lead to lymphedema, which is swelling due to lymph fluid buildup. This lymphedema, if severe, can limit movement, especially of upper or lower extremities, which can then cause secondary pain. Lymphedema is often treated with manual lymphatic drainage and compression garments, but is quite difficult to treat. There are many radiation-induced visceral pain syndromes that could result from radiation therapy. This includes chronic proctitis, cystitis, enteritis, or tenesmus, which all can cause localized problems. Pain in cancer survivors can also be bone pain and bone-related conditions. Cancer that spreads to the bones can often cause significant pain due to growth of the tumor within the bone tissue. These bony metastases can then weaken the bones, making them susceptible to fractures, again causing acute and chronic pain. Osteonecrosis and osteoporosis can result from certain cancer treatments. Treatments like steroids, hormone therapy, and chemotherapy can all weaken bones, increasing the risk of osteoporosis, or weak bones, or osteonecrosis, actual bone death, especially in the jaw or femur. And this can result in chronic pain. Post-treatment fractures can occur. Since cancer treatment can weaken bones, this makes them susceptible to fractures, even after cancer remission. And this too can then result in chronic pain. Chemotherapy, surgery, or radiation may induce ovarian failure and menopause in women. And in men, androgen deprivation therapy for biochemical relapse or metastatic prostate cancer can also increase the risk of osteoporosis. Osteoporosis increases the risk of painful vertebral compression fractures or other bone fractures. Hormone therapy related pain can result from cancers that are treated with hormonal therapy. Arthralgia or joint pain can result from certain hormone therapies, namely aromatase inhibitors such as letrozole, exemestane, or anastrozole that are used in breast cancer. These aromatase inhibitors are used to prevent recurrence of breast cancer and are often used for 3 to 5 years after the completion of treatment of the breast cancer. And this too can result in chronic joint pain. Androgen deprivation therapy for prostate cancer also can cause joint pain. Muscle and bone pain can result from changes in hormone levels in these patients on long-term hormone therapy, and they're left with chronic muscle aches and bone pain. In fact, the high incidence of aromatase inhibitor associated chronic musculoskeletal pain actually impacts patient adherence with a plan of care in as high as 20% of patients. Neuropathic pain syndromes can result from cancer treatment. Neuropathic pain from actual nerve damage can occur and persist even after the initial nerve injury heals. Some patients may develop complex regional pain syndrome after surgery or trauma, and this can lead to severe chronic pain, often in a limb that is out of proportion to the initial injury. Complex regional pain syndrome, untreated, can result not only in significant chronic pain, but also long-term disability and functional impairment due to disuse of the painful limb and subsequent atrophy of muscles and decreased range of motion in the nearby joints. There are many psychological factors as well as central sensitization factors that can contribute to chronic pain in the cancer survivor. Central sensitization may occur in some survivors whereby the central nervous system becomes sensitized or overly responsive to stimuli. This central sensitization can then result in pain that is widespread and out of proportion to any tissue injury. Psychological factors may also contribute to chronic pain in cancer survivors. Anxiety, depression, and post-traumatic stress from the cancer experience can heighten pain perception and contribute to chronic pain syndromes. Emotional distress can also worsen pain by increasing muscle tension and reducing pain tolerance. Cancer survivors may experience psychological distress when pain persists after completion of cancer treatment, And untreated pain can then lead to unnecessary hospital admissions. Fear of cancer recurrence and hypervigilance for recurrence can play a large role in contributing to chronic cancer pain in cancer survivors. The fear of cancer returning can lead to hypervigilance, where survivors may interpret benign physical sensations as pain or recurrence signs, contributing to a chronic pain experience. Autoimmune and inflammatory responses may also contribute to chronic pain in cancer survivors. Immune dysregulation occurs when cancer and its treatments disrupt the immune system, which could then potentially lead to autoimmune or inflammatory responses that contribute to pain. Immune checkpoint inhibitors, a newer form of cancer treatment, can cause autoimmune related side effects, including joint pain and inflammation. Chronic inflammatory conditions can result from cancer treatments, which can then contribute to conditions like rheumatoid arthritis or other inflammatory pain syndromes. It is important to always bear in mind that residual tumor or recurrence of tumor may also contribute to chronic pain in the cancer survivor. Sometimes residual cancer cells remain post-treatment and may cause localized pain in the affected area. Undetected or microscopic disease can be particularly concerning for survivors, as they may be afraid of recurrence of the cancer. Pain as a marker for recurrence is important to monitor. In some patients, persistent or recurrent pain may indicate cancer recurrence. This emphasizes the need for regular follow-up and careful pain assessment in cancer survivors. So when should one worry? What are the concerning signs and symptoms that should prompt rapid assessment in the cancer survivor? Any new or worsening pain merits a detailed history and physical examination, as well as relevant investigations. Pain that is worse at night, night pain, or worse with lying down is a concerning red flag. Signs of cord compression may occur in cancers that spread to the spine or intraspinal contents. These manifest as new onset or worsening back pain, especially thoracic pain which is less common than lumbar pain, or new or worsening pain in a band around the torso, indicating a dermatomal involvement, and pain worse with a Valsalva maneuver, which may be indicative of a fracture. Progressive neurological deficits, such as saddle anesthesia, which is numbness in the S2 dermatome, involving the perineum, the lower buttocks, the posterior proximal thighs, can be concerning and indicative of cord compression. Any new sensory changes in the arms or legs may again indicate cord compression. Muscle weakness, including a sense of heaviness or clumsiness of the limbs, or a stumbling gait or wide-based gait, may be indicative of cord compression. Bowel or bladder changes are concerning. For example, a lax anal sphincter with fecal incontinence or overflow urinary incontinence. Associated symptoms that are concerning for malignancy or cancer recurrence include unexplained weight loss or unintentional weight loss of more than 10 pounds, night sweats, fevers and chills, enlarging masses, or unusual fatigue. Additional worrisome symptoms include excessive bruising or bleeding, which can result from abnormal clotting or low platelets, changes in the appearance of moles or skin, for example, breakdown of skin, changes in the color of skin, dimpling of skin, altered bowel function, again, is worrying, and so is difficulty swallowing or painful swallowing, a persistent cough, or hoarseness of the voice are all concerning for malignancy and should be thoroughly investigated in the cancer survivor. With cancer survivors, we often find that lifestyle and physiological changes that result during the period of having cancer can result in chronic pain. Due to prolonged periods of inactivity during treatment, some survivors experience muscle weakness and joint stiffness, leading to secondary chronic pain. Patients often spend more time than previously bedbound or confined to sitting positions, which can then result in physical deconditioning. The side effects of cancer treatment, for example, intractable nausea from chemotherapy treatment, may also limit a patient's ability to move, again resulting in significant physical deconditioning. Survivors may experience weight gain as a result of this limited physical activity or the result of cancer treatments, for example, chronic steroid use, which can then lead to joint pain and exacerbate musculoskeletal conditions. There are significant psychological challenges that chronic cancer survivors face. There is often a significant coexistence of depression and anxiety, a pervasive fear of cancer recurrence, feelings of uncertainty, and a heightened sense of vulnerability, employment challenges with the resulting stresses of providing for one's family. However, some patients experience post-traumatic growth, positive feelings of gratitude, personal growth, and improved self-esteem. Now that a patient has survived their cancer, what is the role of opioids or chronic opioid therapy, given the current opioid crisis? During acute cancer treatment, the treatment of choice for moderate to severe pain is an opioid. Very appropriate use of opioids. Our strategy with increased pain experienced by the patient undergoing cancer treatment is to then increase the opioid dose. However, while opioids are utilized for the survivor with chronic pain, the focus changes to one of stabilizing and reducing the total opioid dose rather than providing ever escalating dosages. So instead of treating acute pain from cancer treatment with escalating doses of opioids, the patient is left with chronic pain, which we then want to treat by stabilizing the dose and not escalating, which would then lead to tolerance, increased dependence, and side effects of long-term chronic opioid therapy, such as hypogonadism. A helpful strategy to address this with your patient is to carefully explain the rationale for changing the model of care from one of primarily opioids with escalation upon demand to a model where one focuses on using multimodal therapies instead. In terms of pharmacologic agents useful for chronic pain in cancer survivors, this would include the usual neuropathic medications, antidepressants like Cymbalta or duloxetine, anti-epileptic drugs like pregabalin, gabapentin, amitriptyline, nortriptyline, or topical agents for neuropathic pain. For example, lidocaine patches or lidocaine ointment. Acetaminophen and NSAIDs such as celecoxib, naproxen, or ibuprofen can be useful adjuncts. Caution in the patient with kidney disease or liver disease. Topical agents for somatic nociceptive pain can also be helpful. In terms of non-pharmacologic therapies, these are helpful for all types of pain, whether neuropathic or nociceptive, but especially for myofascial pain. physical or occupational therapy, aerobic and strengthening exercises, thermal compresses, either hot or cold, massage, and TENS therapy, transcutaneous electrical nerve stimulation, can be very useful adjuncts to pharmacologic therapies. It is very important for the cancer survivor to engage in regular aerobic activity, not just for the physical benefits, but for the mental benefits too, as is useful thermal therapy and home physical therapy, stretching and strengthening exercises. Counseling or therapy is useful to address comorbid anxiety and depression, as well as to improve coping skills. Complementary therapies, such as acupuncture, massage, and yoga, are also often very supportive additional approaches as an adjunct to pharmacologic therapies. In conclusion, we can see that chronic pain in cancer survivors arises from a combination of treatment effects, residual disease, psychological factors, and lifestyle changes that often occur during cancer treatment. Management of chronic pain in the cancer survivor often requires a multidisciplinary approach that includes pain management specialists, physical therapy, as well as psychological support. There is often opportunity for the use of advanced pain management techniques, nerve blocks, spinal cord stimulators, or intrathecal pumps to manage chronic pain in cancer survivors. It is imperative to address both the physical and the psychological components of chronic pain. And by doing so, healthcare providers can help cancer survivors improve their quality of life. Thank you.